Good evening, everyone. Myself, Dr. Ritu Sabharwal, Head of Emergency Department, Kailash Hospital, Greater Noida. I'm glad to be part of series of toxicology lectures organized by WECA, Medical Crib, and Indian Medical Association, South Delhi branch. My special thanks to Dr. Hamid for giving me this opportunity. The topic of today's lecture is caustic ingestion. As we all know, caustics are substances that cause both functional and histological damage on contact with body surfaces. Major concern with these type of injuries is long-term morbidity. Many household and industrial chemicals have caustic potential. Caustics are broadly divided as alkalis, pH more than 7, and acids with a pH less than 7. The common caustic compounds, alkalis, found are like sodium hydroxide, found in drain openers, oven cleaners, potassium hydroxide, again in drain openers, batteries, calcium hydroxide, found in cement, hair relaxers, perm products, ammonium hydroxide, again found in perm products, dermal peeling, exfoliation, found in toilet bowl cleaners. Few of the acid examples are like sulfuric acid found in automobile batteries, drain openers, explosives, fertilizers, acetic acid like in hair perm neutralizers, pickling solutions, printing, photography, hydrochloric acid like cleaning agents, metal cleaning, swimming pool products, chemical production, hydrofluoric acid found in like rust removers, glass and microchip etching, jewelry cleaners. Injuries by strong acids produce coagulation necrosis. Dissociated hydrogen ions and their associated anion penetrate the tissues, leading to cell death and eschar formation. When ingested acids settle in the stomach, they cause gastric necrosis, may lead to perforation, may lead to hemorrhage. Acid ingestion may be complicated by systemic absorption of the acids, which might be associated with metabolic acidosis, hemolysis, and renal failure. Primary difference between alkali and acid injuries is rapid penetration into the tissues by alkalis. The hydroxide ion easily penetrates tissues, causing immediate cell destruction by protein denaturation and lipid saponification, thrombosis of local microvasculature that leads to further tissue necrosis, a deep tissue injury called liquefaction necrosis. Severe intentional alkali ingestion may cause penetration into the surrounding tissues with the resultant multi-organ injuries, including esophageal injury, gastric perforation, necrosis of the abdominal and mediastinal structures. The caustic exposure tend to fall into three distinct groups: intentional, like adolescent and adult ingestion with suicidal ideation; unintentional ingestion, usually found in children of toddler age group; and other incidental, often occupational or industrial contact exposure. The degree to which a caustic substance produces tissue injury is determined by a number of factors like pH of that material, the concentration of that material, duration of contact of that, how long the contact was, the volume of the caustic substance, and titrable acid and alkaline reserve of the individual. Acids tend to cause significant injury at a pH less than 3 and alkali at a pH more than 11. Ingestion of solids and granular caustics often injure oropharynx, proximal esophagus, whereas the liquid alkali ingestions are characterized by more extensive esophageal and gastric injuries. The consequences of caustic injury over time, to the exposure of the caustic substance, immediately the necrosis happens, like from within seconds. Within 24 to 72 hours, the ulceration happens. After that, the formation of the fibrosis, which takes like 14 to 21 days, followed by the stricture formation, which may take like weeks to months, leading to carcinoma, which may take like 15 to 20 years to develop it. Like the normal burns, the chemical burns also is divided into 3 degrees. The first degree is basically a superficial injury, produces edema and erythema of the mucosa only. The second degree is the penetration through the submucosa and the muscle layer. The third degree is perforation of the wall of the esophagus or the stomach. The esophageal and gastric injuries may be present even when the patient has no complaints, and examination of the mouth and the pharynx is absolutely normal. The patient may present with the symptoms like shortness of breath, difficulty in swallowing, oral pain, pain while swallowing, chest pain, abdominal pain, nausea, and vomitings. The sign which you need to look for is basically the airway, to assess the difficult airway or the airway involvement. Like if you see that a patient is presented with stridor, hoarseness of voice, dysphonia, it means that there is the edema, injury to the upper airway, which causes all these signs. Tachypnea, if there is drooling of saliva, so patient may have the swelling over the mouth, the swelling of the tongue, the swelling of the esophagus. Hematemesis, because due to the necrosis and the erosion of the vessels, hematemesis can occur. Acute abdomen, patient can present with the perforation of the with perforation of the gastric perforation, or the injury to the esophagus and then the perforation. So patient can present with acute abdomen. The severity of complications relates to the depth of the injury. Like superficial mucosal injury is painful, but it resolves without any long-term sequelae. The deeper caustic injuries result in healing by fibrosis and subsequent stricture formation. The full thickness injuries result in perforation and potential fistula formation to either the trachea or, in extreme cases, the aorta. The development of esophageal carcinoma 15 to 20 years after the injection can happen. So the endoscopy remains the gold standard for evaluating the location and the severity of the injury to the esophagus, stomach, and duodenum after caustic ingestion, regardless of the symptoms, plus the intentional ingestion of the caustic substance. An early endoscopy is recommended. If the patient has serious symptoms plus intentional ingestion of the caustic substance, then also there is a early endoscopic recommendation. Endoscopy should be performed within 12 to 24 hours from the time of ingestion to avoid iatrogenic perforation. Late esophagogram after like 2 to 3 weeks after the injection to determine the presence of the strictures can be done. Esophagoscopy should not be performed in patients with evidence of gastrointestinal perforation, significant airway edema, or necrosis, hemodynamic instability. The endoscopic grading of corrosive esophageal and gastric burns is like in grade 2, it's the normal mucosa. The grade 1 is there is a mucosal edema and erythema. The grade 2A, it is basically a superficial injury and the ulceration and blisters, but it is not circumferential. The grade 2B is, it may be superficial injury with limited areas of deeper injury or the circumferential injuries. The grade 3A, you see the necrotic patches scattered here and there, and Grade 3B, it is extensive necrosis. So what do we need to send the laboratory? What investigations need to be done for these patients? Usually the baseline CBC, LFT, KFT, electrolytes, blood grouping and cross matching. If you are suspecting that patient may require surgery, may have perforation, viral screening. But I mean, these are routine thing. I don't think these abnormal test values are predictive of, like, if you have a low pH, you have elevated lactate, deranged LFT, renal failure, thrombocytopenia. So this shows that there may be a transmural necrosis and poor outcome of the patient. The initial normal values do not rule out the transmural necrosis, but it is useful in patient monitoring later on. We can have BVG or ABG in a severe sick patients with strong acid ingestion. It can be associated with severe anion gap, like in sulfuric acid, non-anion gap acidosis, like hydrochloric acid. So what diagnostic imaging we need to do? We can get the chest X-ray and the abdominal X-ray depending upon the symptoms. What we look for in the chest X-ray? The chest X-ray, we can look for mediastinal air, pneumothorax, pleural fluid. In abdominal X-ray, we can see that free air under the diaphragm, and that we can also appreciate in upright chest X-ray also. So these are all suggestive of perforation. We can get the CT thoraco-abdominal with the contrast. Nowadays, recent evidence suggests that CT scans outperform endoscopy, provides the additional benefit of evaluating the serosal surface of the GI tract and early evidence of perforation, and plus it is non-invasive. Ultrasound, endoscopic ultrasound can be used to evaluate and follow up corrosive gastric injury. So management of these injuries, like it is divided into early management and the late management. Early management includes pre-hospital care, emergency department care, consultations in the emergency department, and medications. Late management include esophageal dilatation, esophageal stenting, and esophageal surgery. I will be more covering the A part. Pre-hospital care, dilution, usually, like, we can use the dilution of the caustic agent using water or milk if patient is conscious oriented, may be beneficial if administered within 30 minutes, and remove any adhering particles to oral or esophageal mucosa. Do not use sodium bicarbonate as it generates CO2 and increase the risk of perforation. Do not induce MSS, since vomiting renews the contact of caustic substance with the esophagus and can contribute to aspiration or perforation if it is too forceful. Do not neutralize the substance by using a weak acid or a base. In the emergency department, decontamination can be used. The staff should be wearing personal protective equipment. Removal of soiled or soaked clothing and copious irrigation is advocated. One should start with always A, B, C, D. Airway is the major thing. We need to control the airway, and in any caustic ingestion, we should think of a difficult airway. So we should always anticipate that there might be a difficult airway, and one should be ready with the endotracheal intubation equipments and the backup plan B. What if you are unable to intubate the patient? So you should have the plan B part, which is like cricothyroidotomy, should be readily available. Then gastric emptying and decontamination is contraindicated with activated charcoal using nasogastric tube. No Ryle's tube to be inserted in corrosive poisoning. Other, like supportive care, take care of the breathing using ventilation, and If C part, circulation, if patient is in shock, start with 2 large IV cannulas, start rushing the fluid with crystalloid, and keep the patient. Don't give anything to the patient. Keep the patient nil orally. Surgical consultations, if there is any evidence of perforation, like free air in the peritoneum or mediastinum, evidence of contrast material extravasation, evidence of peritonitis, severe back or retrosternal pain. Endoscopic consultation should be done for small children, all symptomatic older children and the adult, and patient with altered mental status. Obtain a psychiatric consultation for all patients with a history of an intentional ingestion prior to discharge. No specific antidotes are there, only the supportive care is the mainstay of the management. Corticosteroids, still very controversial. Systemic review and meta-analysis by Katibe et al. Concluded that it does not support the use for the prevention of esophageal stricture formation following caustic ingestions. Collagen synthesis inhibitors and acetylcysteine, high dose intravenous calcium chloride may be required for life-threatening dysarrhythmias caused by hydrofluoric acid poisoning. Antibiotics, broad spectrum antibiotics, if evidence of perforation exists, proton pump inhibitors, and parenteral nutrition, essential when enteral feeding cannot be maintained. Support can be achieved by percutaneous, usually jejunostomy feeding, nasoenteral feeding, or total parenteral nutrition. Surgery on esophageal stenting and dilatation. Major ingestion of caustic agents may result in perforation of GI tract and requiring emergency surgery. Laparotomy is generally preferred over the laparoscopic evaluation of posterior gastric visualization. The indication for emergency surgery, esophageal perforation, peritoneal signs, free intraperitoneal air, or the large volume injections more than 150 ml, signs of shock, respiratory distress, persistent lactic acidosis, ascites, and pleural fluid. For grade 2B and 3 injuries without obvious perforation, a recommendation including esophageal rest, early gastrostomy for enteral feeding, and dilatation therapy within weeks with or without stenting. Once the stricture forms, then may be difficult to treat and require stenting or multiple balloon dilatation. The correlation of esophageal injury grade with the morbidity and the intervention. Like you can see the grade 1 esophageal injuries, there is no risk of stricture or the carcinoma. Patient can take orally as tolerated, and the general intervention is basically supportive care. In grade 2A esophageal injury, the strictures tend not to occur, and if in nutritional support, if patient is unable to take per orally, provide nutritional support via nasogastric, orogastric, or percutaneous feeding or total parenteral nutrition. Admission is recommended, but it is all supportive care. In grade 2B or 3 esophageal injuries, these injuries are at risk for hemorrhage and perforation and carcinoma. And the development of carcinoma is late complication. Initiate early percutaneous feeding or TPN. These kinds of patient require intensive care unit admission and may require additional imaging and may require surgical exploration for gastric injuries. So disposition of these patients, like asymptomatic patients, can be discharged from ED after 4 to 6 hours of observation, low risk of ingestion, tolerate food and drink, no signs of drooling, stridor, vomiting. All patients with symptoms or suspected non-accidental injury or mental health concerns may independently warrant admission and need to be addressed. So the key concerns are the ingestion of very small amount of caustic material, even a lick can cause serious esophageal injuries. All symptomatic patients should undergo endoscopy and can be considered for admission. Asymptomatic patients can undergo endoscopy in the emergency department or can be discharged with a very close follow-up and monitoring. Caustic injections are best managed with an interprofessional team approach. Robust legislation is recommended in making container child-proof and ensuring that the proper precautions are maintained in preventing easy child access to caustic chemicals. Improved access to mental health services and social support systems are to be placed and maintained to prevent suicide attempts. Thank you.